Hello, and welcome to the American Medical Association's Climate Change webinar series. This is the third webinar of the series we've organized this summer, and today we will be focusing on decarbonizing the healthcare sector. I'm Dr. Ilse Levin, a member of the American Medical Association's Board of Trustees. I'm a board-certified internist, epidemiologist, and a hospital-based physician for the Mid-Atlantic Permanente Medical Group in the DC Southern Maryland region. Before we begin, I want to thank you for the questions submitted during registration. You can also join the discussion and submit questions at any point during the webinar by joining in the chat. We will get to as many questions as we can during our discussion. Our last two webinars discussed the health impacts of climate change and building climate resilience in healthcare facilities. Today, I'm excited to hear more about how healthcare systems are working to proactively address climate change by reducing their carbon footprint. The U.S. health sector is estimated to be responsible for approximately 8.5% of U.S. greenhouse gas emissions and produces 6 billion tons of waste annually. Greenhouse gas emissions are generally organized into three main categories. Scope 1, direct emissions from owned or directly controlled sources of the healthcare sector. For example, on-site boilers and emissions of certain medical gases. Scope 2, indirect emissions from the generation of purchased energy. And Scope 3, all other indirect emissions, such as those that occur from producing and transporting goods and services across the supply chain. Understanding the different sources of emissions and where health systems can have the most influence is important for deciding how to begin the work of reducing healthcare's carbon footprint. I'm looking forward to today's conversation to hear how these decisions are being made and implemented across four different health systems. I'll introduce our esteemed guests, each of them working on sustainability at their respective health system. After their presentations, we'll move into a Q&A session to address your questions. First, I'd like to welcome Dr. Shirley Kwani. Dr. Kwani is an internal medicine physician and director of graduate medical education at Inova Health System and the co-director and co-founder of the Academy of Distinguished Medical Educators program. As a hospitalist in the endocrine diabetes service, she developed a nutrition, diet, and food sustainability curriculum for Inova residents. Dr. Kwani serves on the executive board for Virginia Clinicians for Climate Action. Second, we'll hear from Genia Sarkar. Ms. Sarkar is the sustainability manager at Rush University Medical Center and adjunct instructor at Rush University. Prior to this role, she worked at Advisory Board, a healthcare consulting company within United Health Group, where she implemented a green team to provide resources to hospitals and healthcare institutions to better understand how they can implement sustainability initiatives. Our third speaker is Dr. Jonathan Slutsman. Dr. Slutsman is the director of the Center for the Environment and Health, medical director for environmental sustainability, and an emergency physician at Massachusetts General Hospital. Prior to a career in medicine, Dr. Slutsman was a consulting environmental engineer, completing projects in environmental, health, and safety assessment. Dr. Slutsman aims to improve the environmental sustainability of healthcare delivery while reducing the environmental costs of healthcare. Our last speaker is Dr. Beth Schenk, who serves as Chief Environmental Stewardship Officer for Providence, a large not-for-profit health system in 7 Western states. Dr. Schenk and her team led the effort to decrease greenhouse gas emissions and other pollution from its operations, while building climate resilience in the communities they serve. Dr. Schenk is an assistant research professor at Washington State University College of Nursing and led the development of the Climate and Health Tool, which measures health professionals' awareness and engagement with climate change and health. Full bios for all our speakers are available on the event page. We're very excited to have all of you with us today, so let's get started. First, we'll hear from Dr. Kwani from Inova Health System.
Hi, thank you so much. I'm very pleased to be here. My name is Shirley Kwani. I am an internist and lifestyle medicine board physician. I am the director of our graduate medical education department at Inova Health System. But I wanted to first introduce myself as a climate advocate, as a physician. And the reason I want to give you my background is because I want people to realize that you don't really need to be you don't have to be an earth scientist or someone who's been involved in this space for your whole career or anything like that. It's really something that comes out of passion and doing your own work and working with others and collaborating. So let me just give you a little bit of what happened to me. So I'm an internist. I worked as a diabetologist. I still do, sorry, in Inova, Fairfax Medical Campus. And I worked part of the endocrine team there. Over time, I started to get a keen interest in nutrition for preventative health for my patients to prevent chronic disease. I went from teaching mainly about insulin management to more about nutrition and prevention. Now, in medical school, we don't learn much about that, just like we don't learn anything about climate change. And so I taught myself and got lifestyle medicine boarded and focused on the nutritional aspect. And that, of course, led me down a path about our focused on our food systems and really our sustainability and really just really the impact food systems have on our environment, of course, the contribution to climate change. And that gave me the motivation to start working on how can we improve this through our food systems, because it seems like a win-win sort of project, win-win diet. So that's what brought me to this space and brought me to my residents and other learners to teach them about this. So I'm going to teach you a little bit about what I have learned and also what we've done as a group, of course, as a team. There's no single person that does it all, but as a team at Inova and beyond in sort of trying to reduce our carbon footprint in the food area. Next slide. So the first thing I want to describe is, because my focus has been on food, my area of decarbonization related to food, I wanted to sort of give you an overview of how food and climate change are linked. So for some background, our food system really contributes at least a quarter of greenhouse gas emissions. It's even projected to be a third in some of the literature. And animal agriculture specifically contributes about half of that, 50%, which is significant. And it's through many mechanisms, through deforestation, for grazing, and then also to create or grow feeding crops for animal agriculture. And so you're really turning our carbon sinks into carbon emitters by doing that. The livestock production, the methane that's produced not only through the output through burps, but others for agricultural practices, the fertilizer and the manure that's produced. So it's a significant amount that we have. And specifically, we know that CO2 is our signature greenhouse gas. So a majority of our emissions are obviously from that source. But you can see food is right up there with, you can see industry and also transportation. And carbon dioxide has obviously a long lifespan, as we know, in our atmosphere up to 2 centuries. But what is less commonly known is that methane emissions contribute up to 10% and has a very potent global warming up to 80 times actually that of carbon dioxide, but shorter lifespan. So it could be just over a decade, about 12 years is the projection. So moving on this, really moving the needle with this, with methane production, can actually make a significant difference. Next slide, please. So as you can see, and forgive me for the 2 slides combined here, but you can see that food emissions are so impactful. On the left side, you can see that even if we decarbonize everything else, we can really not meet the Paris Agreement unless we eat less meat and shift our diets towards plant-based or plant-forward foods. And on the right, you can see that we have the Eat Lancet Commission. Many of you, I'm sure, are familiar with this, but this is the report, the original report addressing this issue of food in the Anthropocene. And you can see that the Eat Lancet Commission was formed actually in 2013, 2014. They published this, and it was a creation of 37 scientists from 16 countries globally. And they developed the planetary health diet, and it's really for sustainable global diets. And this has become a wonderful resource. I would recommend everyone going to the Eat Lancet resource And it has position papers for, food to eat Lancet or the Eat Diet in healthcare facilities and your other environments, and also background on how to do this, and of course the details of the report itself. But it's a wonderful interactive website. I would recommend everyone trying to access that. Next slide, please. So this is also a little busy, but I wanted you to focus both on how plant-based diets affect the environment and also how they affect our health as well. And being a physician, this is very important to me to merge the two. So on the left side, you can see the graph. This is showing greenhouse gas footprints of various dietary patterns. And this is taken from Our World in Data, which is Hannah Ritchie's UK website, which has fantastic graphs and are used. It's open access, and you can use these actually for your educational purposes. But I love this website, so please take a look at that. But you can see here that on the top, you have the average standard American diet, which consists of a large proportion of animal-based products. And as compared to more plant-based or more plant-forward dietary patterns, as you go down, you can see that the actual footprint lowers. And in fact, in this and other studies, you can see that if you were to go plant-based for even 2/3 of your meals, you can cut food-related carbon emissions by about 60%. And even going 100% plant-based, which is what I and my family have adopted, it would lead to approximately 85% decrease. So it's very significant. And this is great when you're talking to patients or friends and colleagues about how they can make individual changes if they care about climate change and climate mitigation. So, and then on the right, you can see this is a graph where the x-axis is showing the relative risk of mortality, and on the y-axis, the average relative environmental impact. And what becomes apparent looking at this right away is that unprocessed red meat and processed red meat are foods that really have both the highest risk of mortality as well as the highest environmental impact. And you can see that in the square above on the right top area. Whereas in contrast, plant-based foods, which are in green, have the lowest environmental footprint as well as the lowest risk of mortality. And that's been shown in many, many studies, systematic reviews, meta-analyses about the benefits actually of adopting the plant-based dietary patterns of some sort. And it doesn't mean necessarily that people have to go completely vegan, as I demonstrated with the left side, but really just making any small changes make a difference. And if you're eating lower really on the food change, it's really a win-win both for individual and planetary health. Next slide, please. So what can we do, or what we have done really? And I'm an educator, medical educator in the graduate medical education space, overseeing really our wonderful residents and fellows over at Inova Health System, but also our students. And so what we try to do, and this is try to increase the awareness actually of these beneficial effects, of plant-based dietary patterns. And then my colleague and I, Dr. Chicheo at Cooper Healthcare, and I conducted some annual educational sessions. And these were not very long sessions. They were with internal medicine residents at both institutions. And these were brief, but they were interactive. And what we were able to see is that, and you can appreciate this, and that's what's on the left side, is that we can see even with these brief educational sessions, or didactic sessions, or even small group discussions, you can really change attitudes about climate change, and you can really change confidence in their abilities to counsel patients, even with these brief sessions. And this has been shown, of course, with definitely more robust studies when they address sort of dietary patterns and how to integrate this in medical education. Next slide, please. So what this did actually by this education and this awareness really led to my residents and even junior faculty even thinking about how can we change our environment, our food environment within the healthcare system. They wanted to do two things. They wanted to align it with the American Heart Association and even the USDA dietary guidelines that are recommended for Americans, and also the overlap with Eat Lancet guidelines. And really, there is massive overlap. overlap, and people are not aware of that. So because of that, we created a plan for a QI project. And what was noted within our environment at the Fairfax Hospital is that our physician and provider, which includes our attending physicians, our resident and fellow physicians, and our advanced practice providers, we actually have a large cafeteria there. But what is noted that really the menus were less healthy than we would like, and also not as sustainable as we would like. And really no one had questioned this. It was just about, what was available at the time. And really, this was spearheaded by my residents to say, hey, can we have maybe a little bit more sustainable food options, and also that correlate with health, because of course that's an important symbol as well in healthcare, is that we should adopt these healthy behaviors. So the first thing we did was survey the providers, and what we found, really looking at their own dietary preferences and food recommendations, is that out of 180 respondents, 80% of our group really wanted to have more of a Mediterranean plant-based dietary pattern available to them, and they preferred that, and they had adopted that at home, which was a surprise to all of us, actually. And so with that data, they wanted more plant-based options. So we offered them really what was available through our food services, really not something that was just, too aspirational. It was really what could be available there within your own system. And they really gave us an idea of what kind of options they wanted, specifically plant protein, more of that available to them. Also, some interesting non-dairy and gluten-free options for people who had some intolerances and even allergies, and that we would have never known as well without this. So that was nice, and provide some inclusion. And basically over the 18 months, the menu was transformed. And this is really done because we have extremely receptive leadership. It was an easy lift for us. Our Met staff president was very receptive to this. Also, an advocate for prevention of diabetes, as we discussed many times. And then our food services lead was more than willing to change this. So really, it wasn't that difficult to move the needle on this. And then we noted some differences we wanted between the two menus. We wanted less red and processed meat. And of course, like I mentioned before, more plant protein was an important option as well. Next slide, please. So what did we find? And this is a little busy too, but this is really a snapshot, and looking at the differences between the fall of 2023 and spring of 2025. And there were several iterations of the menu, and really now it's a superb menu that is offered, so healthful, and also so many options, which we're also very grateful for. So you can see it makes a big difference, but you can see here that the changes between the physician cafeteria menu from 23 to 25 was significant. And the bar graph here on the large left here showed the changes in the greenhouse gas impact of that change. Now, this was using a model of greenhouse gas per 100 grams of protein, the environmental impact of the Food Explorer, which is also a model that was used from ourworldandata.org. And that bar graph, you can see, showed estimated changes per month of greenhouse gases. And then the smaller table here, I just want to alert you to just the area in red, which shows the delta change. And it was quite significant, and the top being more plant-based options available, whole food plant-based options specifically, because we also wanted to reduce processed food, which we know is not really very healthy. And then, of course, the changes in meat and dairy, which also were reduced, as you can see below. So there was a significant difference. And you can appreciate here that decreasing the carbon-heavy foods like ruminant meats and increasing low-carbon foods like plant-based foods per serving really makes a difference, because in our cafeteria, the approximate amount that we serve is for about 800 meals per day. So this could make a big difference in terms of food procurement and the changes. Next slide. And this is my final slide, just to really just highlight the wonderful work our sustainability and green teams are doing over at Inova. But specifically, along with the menu changes and other changes that we're working on, we also have a composting program that has worked to reduce waste in food. And this is actually at all our 5 hospitals now. They expanded pretty rapidly, and really a significant amount has decreased. And we have a pickup service, and that produces some wonderful compost for our gardens and for others to use. But about 400,000 pounds have been composted actually since the program began in 23 as well. So I'm very proud of that with our team. So this is obviously what we can do as a team. But again, my background was really in diabetes and metabolic health, and educating myself in this area, and then really engaging with wonderful people at my system and others, like my wonderful colleague, Dr. Churcheo at Cooper Healthcare, that sort of allows us to make these changes rapidly. Anyway, I'll stop there and let my other colleagues continue. Thank you.
Thank you, Dr. Kwani, for that great presentation. Next, we'll hear from Ms. Sarkar from Rush University Medical Center.
Thank you. Hi, everyone. As was introduced, I'm a sustainability manager at Rush University Medical Center, and today I wanted to share a few of the ways we're decarbonizing while keeping community health and equity at the forefront of our efforts, which I'm personally very passionate about. Next slide, please. So, for those of you who may not be familiar with us, Rush University System for Health is an academic medical system that includes 3 inpatient campuses and a broader outpatient network in Illinois. 2 of our campuses, Rush University Medical Center and Oak Park, are located on the west side of Chicago. And based on Rush's research and community health needs assessments, we found that there's about a 14 to 16-year life expectancy gap between Chicago's predominantly white affluent neighborhoods, such as in the Loop area, versus our historically disadvantaged west side. And along with this, you can see there's an income gap, which is inextricably linked to that life expectancy gap. And recognizing these gaps and aiming to eliminate it is the backbone of our organization and our equity framework. More specifically, we're aiming to give everyone a chance at a healthy, long life. And so in order to do so, Rush adopted an anchor mission strategy as one of the largest employers on the West Side. What this means is that we're investing in local hiring, procurement, and community engagement to the best of our abilities. Next slide, please. But those graphics that I just showed don't tell the entire story. On the left side, you'll see that there's a distribution of the Environmental Justice Index in Chicago. And on the right side, you'll see Chicago's Cool Shy initiative that took place in 2023 to measure heat across communities. And these images mirror the ones that I just showed you, that the West Side is experiencing disproportionate environmental burdens compared to more affluent neighborhoods. And even though our anchor mission strategy is addressing those root causes of inequities, it's important that we also work on our decarbonization efforts to ensure that those populations that we're trying to help are going to succeed in that from an environmental standpoint. Next slide, please. So in recognizing this pattern, our health system has really driven our climate mitigation work with 2 main goals. One being to decrease our scope 1 and 2 emissions by 50% by 2030, and the second as achieving net zero emissions by 2050. And now these are very lofty goals, and we have these graphs that showcase where our progress is, but we've been working on understanding ways we can achieve decarbonization in a way that amplifies and improves our ongoing equity efforts, or what's not going on in the graphs visually, but a story that we could tell based on what we're actually doing in the communities. Next slide, please. So the first effort I wanted to highlight is our partnership with a local laundry service called Fillmore Linen. And So, recognizing all of these inequities for our West Siders, Rush joined West Side United along with 5 health systems in the area to promote racial equity and cut the life expectancy gap in half by 2030 across 9 West Side neighborhoods specifically. And preliminary discussions amongst this West Side United group identified laundry as a high volume service that could be relocated to the West Side to drive economic opportunity and reduce environmental impact. So it was a good 2-for-1 there. And our local institutions were formally sending laundry to the western side of Illinois or sometimes out of the state to neighboring Wisconsin. And these laundry facilities usually were older and had less efficient machinery. So once Fillmore opened up in 2024, we saved approximately 16,000 metric tons of carbon dioxide equivalent from shifting our laundry service to a closer site compared to our previous laundry contract. And that's over the course of the first year alone. This is a 75% decrease in our transportation-related emissions from laundry. An additional benefit to that, of course, is that we're limiting harmful pollutants from trucks on the highways, which pass right through the west side of Chicago. And not to mention, the facility is fitted with new high-efficiency equipment, which has decreased our natural gas and electricity-related emissions, as well as our water used for our laundry linen alone per year. But this opportunity isn't just focused on the environmental piece. We also have had half of the 80 current full-time staff reside in West Side zip codes and receive an average employee wage of about $21 per hour, or approximately $44,000 annually. And for context, that's 25% higher than the median income of $33,000 in the North Lawndale neighborhood, where Fillmore is located. Along with this, employees are also getting a chance for maybe the first times in their life to enroll in employer-sponsored health insurance, as well as participate in other wraparound services like housing and transportation support, as well as financial and substance abuse counseling. And this is all while excelling in their operations with on-time deliveries and achieving some key laundry metrics like fill rate and ragging out. So Rush's partnership with Fillmore is one that I'm personally very proud of, given that it's a powerful example of how healthcare can drive equity, sustainability, and operational excellence. Next slide, please. So another project that we've worked on in collaboration with consultants called Resource Innovations was to develop a 5-year EV charging vision with the ultimate goal of maximizing the percent of electric miles driven by Rush visitors and staff. Now, at first glance, this might not seem like an equity initiative at first, but we really tried to focus on first addressing the dearth of EV charging options on the west side, what we are calling a charging desert, and second, reducing pollution from vehicle tailpipe emissions, which improves local air quality. Additionally, on top of that, this effort has the opportunity to decrease our emissions from employee, patient, travel to campus, so our scope 3, category 7 and 9 emissions. Resource Innovations helped us to evaluate the chargers we should add, as well as engage with key stakeholders for our pilot project, which ultimately led to about 25 chargers being installed in our public-facing garage. And that pilot was at no cost to the users themselves for charging in exchange for their feedback. And we heard a lot from a lot of different users with regards to those EV chargers, but the pilot was successful. And I think one of the biggest complaints that we heard was how to address the fact that this EV charger was behind a paywall in our parking garage. So that's something we're actively thinking about, of how to place community electric vehicle charging to promote alternative forms of transport, not only to and from our campus, but also for the larger community to have that option. And ultimately, we're hoping that this could be an impetus for shifting transit opportunities away from gasoline-based vehicles and collecting better data with regards to emissions reductions of how patients get to and from, and staff get to and from our facility. Next slide, please. Lastly, we are decreasing our scope 1 and 2 emissions by focusing on one of our largest emissions categories, which is purchased electricity. So recently, Rush committed to multi-year contracts with solar power partners through the Illinois Community Solar Program. And this is an innovative initiative that helps institutions like Rush reduce their carbon footprint and support renewable energy access in local communities. So, if you're not familiar with how community solar works, it allows subscribers from homeowners all the way to small businesses and hospitals to share the benefits of offsite solar farms. And these solar farms ultimately add renewable electricity into the regional power grid. And then subscribers can receive utility bill credits based on the portion of the power produced. And the reason that this is very cost effective at this time is that there are a lot of state incentives involved as well. So this is a win-win in terms of investing in the community as well as getting cost savings for our energy use. And in particular, the ways that this helps the community is that solar projects tend to benefit areas that have historically faced high pollution burdens and lacked access to clean energy investments. These are helping to develop local jobs, infrastructure, and more affordable energy, all in the neighborhoods that need them most. And so we're hoping that once these contracts come online in early 2027 and we receive our renewable energy credits, this will be set to cover more than 30% of at least main campuses' electricity consumption, which is an approximate 50% decrease in our scope 2 emissions for main campus, which is huge. Ultimately, we're excited about this opportunity, not only to reduce greenhouse gas emissions, but also to align with our mission and longstanding commitment to improving the health and vitality of Chicago. So next slide. Thank you so much for taking the time to listen on about the decarbonization efforts that we're rooting in community health. And I'll pass it off to our next speaker.
Thank you for sharing that amazing work, Ms. Sarkar. Up next, we'll hear from Dr. Sluman from Massachusetts General Hospital.
Thanks so much. It's my pleasure to be here. And I'm going to talk about culture and physician leadership. So next slide. I have some conflicts to report that you can read on your own now or later. Next slide. The way I see it, the end goal of all of our work in environmental sustainability is culture change. The end state is a place where everybody is thinking about sustainability as part of their core functions of their jobs. That to some degree, my job and Beth's job and Genia's job and so many other jobs become less and less important as the sustainability leader when everybody is just doing sustainability as part of their general tasks. We all do the right thing for everyone because that's what we normally do. That's where we want to get. The great question, though, is how do we get from where we are today to that end state? Next slide. I would argue, and I thoroughly recognize my bias here, that physicians are critical to culture change in medicine and healthcare institutions. First, not exclusively, but physicians are already dedicated to doing no harm. You see here a photo from actually in Chicago, so a little hat tip to Genia there. This is at the University of Illinois, Chicago, a statue of Hippocrates. And I actually did not take the Hippocratic Oath. I took the Declaration of Geneva, which is a much more modern version, but we all know the Hippocratic Oath with its heart of doing no harm. That is a key basis of the physician, among other healthcare professionals' roles. Second, so much of healthcare is driven by physicians. We are responsible for training the next generation of healthcare leaders and other physicians. We lead care teams. We run hospitals. We do so much more. And that's not to discount all of the other things that so many other healthcare professionals do that are absolutely important and critical. As I said, I recognize my bias here. Next slide. What you see here is a very rough timeline of significant sustainability work at my organization, Mass General Brigham. And there are a few points that I'd like to make when I show this chart. And the first is that this is not new to us. We've been doing this for decades. There were even things before the early 2000s, which is where this chart starts. But the key is that we've been doing this for a long time. But the second is that if you look from left to right, from longer ago to closer to the present, the dots are getting closer together. And the biggest change that happened in that time, at that inflection point, is more clinician involvement and leadership. It's true that you need organizational leadership on board to make gains in the world of environmental sustainability. But just as we physicians might talk about managing your consultant being a skill, managing or working with your administration is also a skill, and something where having clinician leadership really drives things forward. The clinicians, particularly physicians in this sense, know the front lines, and we can expand thinking about sustainability beyond facilities engineering, which is traditionally where it has started in many organizations, mine certainly included. We can start talking about things like sustainability at the bedside. We can start talking about appropriate use of resources for diagnostics and therapeutics and how that impacts our patients. And we can talk with our, for lack of a better term, support services, which I actually think is a terrible phrase for all of the other departments in the hospital that are non-clinical. But in working with our support services for many years, they really see their mission as providing whatever is needed for patient care. So if a physician or a pharmacist or a nurse or somebody who's directly at the bedside taking care of a patient says to one of our support services leaders, you know, this thing would be better to take care of patients, they want nothing more than to make that happen. That is what they see as their mission. So having those clinicians involved in sustainability really can move those other departments forward. So let's go to the next slide. I'm going to talk about two examples where we are on the, I'll say, leading edge of culture change actually happening in our institution. And I don't think that we are the farthest along by far of any organization in healthcare, but we've had some pretty good successes. And I'll talk a little bit about how they happen. What you see here is a lowly bronchoscope. This happens to be a disposable model. It's not important who makes it. That's not relevant to the story. But a few years back, I received an email from our director of perioperative services. And he had gotten a request from the chief of thoracic surgery to use disposable bronchoscopes in our ORs. And we do a lot of surgical procedures in our institution. A lot of them involve bronchoscopes. And our director of perioperative services got this request. His first thought, to his great credit, was, disposable bronchoscopes, those don't sound very sustainable environmentally. I'm going to ask Dr. Slutsman what he thinks about it. And I knew nothing about this until he reached out to me. This was simply his response to years of sitting in sustainable purchasing meetings where we would talk about different things that were happening in the hospital, and periodically I'd raise my hand and say, hey, is that really the most sustainable option? Or let's talk about what this means or how we can measure it or what we could do better. And after years of that, it really kind of got into it. And he started thinking about it too. So that when he got this request, his first thought was not, oh, what's it going to cost financially? Or do we have the operational capacity to make this switch? Or is it better for patients? It was, that doesn't sound very environmentally good. So he forwarded it to me, and that led to months of discussions internally and externally with the proposed vendor about what this device really means, and do we need it to be disposable, or can we stick with the multi-use devices that we've been using for, I don't know, generations? And is this safe for our patients? What could we really be doing? It opened up many venues into what a vendor will or won't say in order to sell their products, what the data actually support and the quality of the data behind them, and so on. But it all really started with this one non-clinician saying, this doesn't sound like maybe the best idea. Let's go to the next slide. And that brings us to another example. So that one was a clinical device that is going to be used many, many times in our facility. And this is a piece of infrastructure. We currently have, I don't have a live photograph of what this site looks like right now, but I can tell you that the tower on the right is mostly constructed. The tower on the left hasn't been touched yet. This is a new 1 million square foot clinical building on our campus that's currently going up. It's the biggest, the newest in all of our health system. It's going to house a lot of things: ORs, inpatient beds, procedural spaces, some pharmacy space, some kitchen space, some parking for cars and bicycles, and lots of other things. It was designed over multiple years, as you would expect such a building to be developed. And at some point, I got involved. And again, I'm just a lowly clinician who happens to know environmental engineering. And by the time I got involved, we were probably, I don't know, half to 3/4 done with the design. And I said, hey, can we do better? And it was, well, what could we do better about? This triggered a lot of discussion among our hospital leadership, our health system leadership, the architects, the engineers to say, oh, maybe we can actually do better. And what we ended up doing was removing all fossil fuel infrastructure from the building, except for emergency generators. We stretched it so that 85% of the energy required for this building comes from renewable sources, and the remaining 15% is steam from a cogeneration plant across the Charles River from the hospital, which we already use on our campus for much of our heat and process steam. And we did it using reasonable technology, nothing really outlandish or crazy, just taking technology from other places and putting it into a hospital. It took a lot of effort, it took a lot of discussion, and it added to the cost of the building. But I'll tell you, this is a very, very expensive project. It added less than 0.5% to the cost to make it better. And it will be net zero capable on the day that it opens. So we did that through partnership with clinicians and engineers and architects, but really it started with clinicians gaining the respect of the leadership to be able to have the discussion. So I hope that in these last few minutes, I've been able to give you a little bit of background on why I think clinician leadership really is necessary to achieve that end state of culture change where really most of our jobs, hopefully, are being done for us. So thank you.
Thank you, Dr. Sluman, for that lovely presentation. And lastly, we'll hear from Dr. Shank from Providence. Dr. Shank, the floor is yours.
Thank you so much. And what great listening opportunities this morning. Thank you all for sharing your stories. I love to hear what's going on elsewhere and around the country. Next slide, please. Providence is a large health system in 7 Western states, actually including the 4 largest states. I mention that because the geography is sometimes challenging. And you can see them lit up there. And also you see India on the map. Why did I put that there? Because we have a tech center in India, which is very important for our data processing. So I'll tell you more about that. You can read a little bit about our numbers. Next slide. I'm going to show you primarily today our mitigation work, because this is the theme of today's presentation is decarbonization. But quickly, just to address other things that we're doing in our resilience planning. Right now, because of a California law that applies to all of us, all of our sites, not just our California sites, we will do our first climate related financial risk reporting in 4 months. It's due January 1. It has been fascinating. We're working with multiple leadership groups across the organization to interview them about what are their perceptions about climate risk. And there's a great story to be told there that we have learned lots and lots of detail. And we've also learned that we don't think about it very holistically yet. So this is part of, Jonathan, your word, a culture change that will help us be better prepared. In our part of the world, we deal with fires, smoke, floods, and here one of our clinics burned to the ground, and we almost evacuated a large hospital. So it's a very big issue, a lot going on. We also do a lot with our advocacy partnerships like this, our sharing, and I'll talk more about that. But mostly I'm going to race through our mitigation work. So this is our phrase that we developed called We Act. stands for waste, energy, water, agriculture, food, chemicals, and transportation. And I'm going to walk through each. So next slide, please. First is waste. Now, waste is an important issue for one reason, because everybody asks about it. It's the thing we get the most questions about are waste and food. So those are great engagement topics. We use it all the time. We talk to everybody about it. Also, it's really important because waste points to consumption. And consumption is really what we're trying to drive down here. How much do we really have to buy all this stuff? How could we move more toward reusables? Could we do better with our waste diversion? So we only have two publicly stated goals. This is the second one, that we hope to divert at least 50% away from landfill and hazardous streams by 2030. Just want to point out that green box, the avoided waste, is really what I consider the most important. And that's the waste we don't create. And those are examples like washable isolation gowns, like non-single-use bronchoscopes, like your usable dishware. And we're actually measuring it. So we're asking our local teams to help measure that through either actual comparisons to disposable or estimated. So that's an important piece. We track about 30 waste streams on our scorecard. Next slide, please. So to look at energy and water and agriculture food, rather briefly, like everyone else, we're working hard on our energy efficiency and water. We are on renewable electricity at about 100 of our facilities. We have about 700. And we are thinking that we're going to achieve our 100% renewable electricity across the entire footprint by 2030. Natural gas is a lot harder, as you all know. We too have a few buildings that have no fossil fuel infrastructure except for generators, and working in that direction. It's a hard change to make because most of our buildings were built 60 years ago, 60 or even 70. We also are primarily in drought zones, so we focus on our water for our relationships in our communities and also the safety in our communities. So we've made major strides, particularly in California and Oregon, to reduce our water through conservation. Now, our agriculture and food, following Dr. Kwani's terrific presentation, we are working specifically on 3 goals, and this is super high level. We have 51 cafeterias across these states, and they're all working on these broad goals. To reduce the carbon intensity of meals served, like you said, by moving toward plant forward, to more appropriate sizes of portions for meat, et cetera. And we track that based on our purchases by weight. So how many pounds of meat did we purchase? And we have that information for each site. For waste reduction, from the food prep side, what can we do to actually waste less food that we're cutting up? What can we use to use it again in the next meal the next day? We have composting at, I think it's 41 of our sites right now. We have a few that it's kind of hard, like small cities in Alaska. Working on our packaging, because we really backslid during the pandemic. We went to a lot more disposable everything. So we have a good, better, best program right now that's rolling out. I am optimistic about it. And then we also track our food donations. That's required in California. We think it's a best practice everywhere. So we include that on our scorecard as well. And then healthy foods. I mean, here we are for health. So we try and talk about it. We have multiple gardens. We have CSA shares. We have a prescription produce program. So this one, as I say, gets a lot of attention because just like we all throw stuff away every day, we all eat every day. So it's a great engagement point. Next slide. We work on chemicals. It used to be chemicals of concern, chemicals that caused rashes and asthma and were carcinogens, et cetera. And we still address those. And we've also really taken on the chemicals that are greenhouse gases. You may have heard of Dr. Brian Cheesebro, anesthesiologist for Providence and our medical director. And he has really brought solutions to the nation, particularly for our nitrous oxide disconnections. We have toolkits that are available to everyone on our website, and there's a really great one about nitrous oxide disconnections if you or any of the listeners are interested. Also making good progress with our volatile anesthetics, et cetera. And recently, he and others have worked hard on the inhalers with both the propellants as greenhouse gases and the ways that these are delivered. And so we will be posting soon a national formulary for inhaler carbon emissions. It's complicated. Refrigerants, harder than you'd think to get that information, and higher than we thought because we have so many old buildings that use old refrigerants. Our travel is a big piece of our footprint, it turns out, and we measure these 4 areas. Business travel includes flights, rental cars, hotels, and reimbursed miles when people drive their own vehicle and get reimbursed for that, going to different clinics and home care, et cetera. We also track our care, that's the care delivery. We also track supply chain to an extent. This is something that we're working on. And what we've done so far has shown us that it's higher than we thought. So this would be category 4 in your greenhouse gas inventory, higher than we thought. So we're really paying more attention to that. And employee commuting is huge. We have 122,000 caregivers. That's a lot of carbon. So we measure that every other year and put that forward. Next slide, please. So I've mentioned this scorecard. So this is what we work on with our wonderful team in India, and we have data that starts in 2019. And what I'm showing you here is super data heavy, hard to read pages that are really the database. But it's amazing because every month for every hospital and about 80% of our clinics, we now have the cost, the use, and the carbon for all of our metrics that come in every month. Some things it's every quarter, but mostly it's every month. So then every month we basically have a greenhouse gas inventory, and we also have ways to compare performance. So we normalize these data, for instance, energy use index, which you're familiar with, or kilograms CO2 per OR. You know, we have dozens of them. So if you go to the next slide, because that's really hard to read, and because we're working with people who don't like numbers, most people, I don't understand it, but most people don't seem to like numbers that much. Their eyes glaze over when you show them a slide like that. But something like this makes it easier for them to grasp in a quick look. Oh, I see. Green is good. Over to the right is good. What are the areas I could work on? This is just an example from a hospital somewhere. And this sort of thing has been a game changer for us in terms of getting the message across. So again, back to culture. One thing we say is that data are the backbone to our work. We don't feel like we can really know where we're going or where we need to go or how much progress we've made if we're not measuring. And 2, engagement is the secret sauce. So the engagement is really about the culture change. So this has been enormously important for us. Next slide, just a little bit of comment about how we're doing, and this is my last slide. So we have reduced our emissions. If you'd go to the next slide, by about 22%. Our goal is 5% a year, starting in 2021. So we're on track. We have met our waste target at a few sites. I already mentioned about renewable electricity, carbon emissions from different subsets. As you can see, we all 54 of our sites earned the Sustainable Healthcare certification from the Joint Commission last year. I've talked about our scorecard, and also this saves money. This is a really important thing. I like to save it till the end because it's not the main reason we do this. We do this for health and for our ethical commitments. But yeah, it's great. By saving resources and being smart and efficient, we save significant dollars too. Thank you very much.
Thank you to all our presenters for sharing all those valuable insights into how health systems are approaching decarbonization. I'm sure there are questions, so let's get to those now. We'll start with some of the questions that our audience submitted when they registered for the event, but I also encourage anyone watching to join the chat and ask questions there. We'll get to as many of them as we can. All right, so the first question is going to be for Ms. Sarkar. Are there any plans to transition to hybrid or fully electric EMS vehicles?
We currently contract our EMS vehicles out, but that would be something that would fall into what we're currently working on of like a sustainable procurement policy to impose some of those guidelines and feedback to our vendors. But we are looking to electrify our fleet in other ways for vehicles that we do have on campus, like for security, and for a daycare we have on campus as well.
Wonderful. And to Dr. Kwani, what are SSBs, and are there any future plans to incorporate alcohol in your work on educating patients?
Oh, interesting question. So sugar sweetened beverages, SSBs, yeah, we have we have tried to transition to sort of iced tea things to offer instead, and obviously coffee, which have, you know, nutritional benefits in general, as long as you don't add all those sweeteners in there. We've been trying to reduce that. Again, I said about ultra processed food, less of a focus, because we used to have more ultra processed snacks that were available to the providers. And again, these are available the whole time. So for residents, they have at least 2 meals. They can have at least 2 meals per day. I mean, it's quite significant. So we tried to reduce that. In terms of alcohol, that's individual on a patient level. Obviously, we're not doing it in the hospital setting in terms of affecting that environment, because hopefully nobody's drinking alcohol on site. But in general, yeah, there's been a decrease actually in the rate of alcohol consumption because of the data that's come out about the association, the stronger association that we weren't aware of with cancer. So I think it's a positive thing to mention, obviously, with any dietary counseling.
Excellent. This is for Dr. Schenk. Can you speak in more detail to the removal of desflurane and how were anesthesiologists at Providence engaged in that decision? And then did you have any challenges removing desflurane from your formulary?
Our leader is an anesthesiologist, as mentioned, Dr. Cheesebro, and he had been working on that for some years before we finally removed it from the formulary, which was just in 2024. A lot of conversations. He did something really important, which was measure individual impact per anesthesiologist. And he described it in Hummer miles. You may have seen some of his reports because this is probably close to 10 years old. And so oftentimes when an anesthesiologist realized, oh, wow, I'm way above my peers and we don't need that drug. I mean, I drive a Prius. Why would I want to cause this sort of pollution in my work? It just easily happened. Now, that's not the same as getting it off the formulary. That took a couple of years of constant conversations with the peri-op committee, the pharmacy committee. We have 7 regions. We're not completely standardized. We have to usually go through 7 different decision processes. So that was just continuing to report the facts, to report progress. And you know, also he did some work to demonstrate that the clinical efficacy was, it did not require desflurane. And that was an education piece because some thought that there were some significant advantages. So it took a while, but was doable.
Interesting. Dr. Slutzman, I have a question for you. Is your organization's team, which oversee energy consumption, paying the electric and gas bills? And are they going to track the energy cost savings to document the cost savings benefit? And to add to that, possibly would they use those savings to pay for future sustainable infrastructure?
Okay, there are a bunch of questions there. Our utilities are all managed at the health system level already. And we purchase renewable electricity for every facility for which we can. There are some that we're legally prevented from doing so, but about 80% of our system's electricity is renewable already, 100% for some facilities and then less for others. That gets tracked. We track the emissions from all of our electricity and other energy sources annually, going back many years. We actually have to report to the city of Boston and the Commonwealth of Massachusetts now. So that is done. I'll be honest, our initial foray into renewable energy, renewable electricity, was for financial reasons, not environmental. We locked in some very favorable electric rates by buying into a wind farm in New Hampshire, not far from us. And now we're expanding our renewable energy purchases. So some of it is financially beneficial, some of it less so. As far as putting it towards future benefits, I can have a very long conversation about the benefits and drawbacks of a green revolving fund. We do not use one. We demonstrate our savings as we go along, and we spend money where we think that it's necessary to spend money to do the right thing. And that's, I think, the best way to answer whether we do that. Our CFO, who actually heads our Climate and Sustainability Leadership Council, is generally against left pocket, right pocket accounting. Ultimately, it's all dollars for the health system and they get spent by the health system. So we set our priorities, we spend the money where it needs to go.
So I have one more question for you, Dr. Slutsman. I think, unfortunately, I don't have more time than that, but are there examples or do you have any thoughts on possible national incentives that could help promote decarbonization?
Oh, that's a very long question for the 2 minutes we have remaining. There's ample opportunity for national incentives, and my personal bent is that in circumstances where there's a societal benefit to something, but not a local benefit to something, then there is a role for governmental incentives to push us to do the right thing for society. And I think that generally applies to things like electricity and other energy sources where the benefits accrue to people other than the people who are spending for it. So I would say, yeah, there's a role for that. Whether it comes back or continues is out of my hands.
Well, thank you again to our amazing panel for taking the time to provide insights into how their health systems are reducing their carbon footprint and improving sustainability. We appreciate the important work that you do and are grateful you were able to be here to share your expertise on this topic. I also want to extend my gratitude to our audience. Thank you for your interest in this topic and for spending your valuable time with us. If you were not able to make all the events in the series, know that all webinars were recorded and are available on AMA's EdHub website, for which the link will be shared in the chat. CME is available for today's webinar. Just make sure you're signed into your free AMA EdHub account and click on Take Quiz. Thank you for joining us today. We look forward to seeing you at our future AMA educational webinars.